Actinic keratosis and squamous cell carcinoma. My name is Renee Lee, and this is my presentation for multidimensional health class, our dermatology week discussion. Actinic keratosis, or also known as an AK, is a precancerous lesion. Risk factors for an AK is fair skin, light eyes or hair, sun damage, UV exposure to tanning beds. A description is a erythematous, flat, papule, or thin plaque. It often feels rough or gritty, and that can be described as a sandpaper feeling to the lesion. Most AKs are less than 6 millimeters in size. Treatment of an AK is usually liquid nitrogen or curettage. It can be managed in the primary care office. Depending on the size, it may need a biopsy if the lesion is greater than 6 millimeters, tender, hypertrophic, rapidly growing, or ulcerated. That may be signs that it might be a squamous cell carcinoma. Follow-up for AKs is every 6 to 12 months for skin checks. Squamous cell carcinoma, or also known as SCC. Risk factors for SCC is white or fair skin and the use of tanning beds, exposed to sun. Description is a well-defined erythematous nodule or papule. It usually has a central ulceration and crust. It's firm with palpation and it grows outward. Usually it bleeds with minor trauma and then crusts back over. It's usually found on the head, neck, forearms, and dorsal hands where skin is more exposed to the sun. It originates from a keratinocytes. SCC cells are past the dermal and epidermal junction. If a keratinocyte atypia is confined just to the epidermis, it's classified as SCC in pseudo or Bowen's disease. Treatment for SCCs is usually a referral to dermatology. They'll do a tangential shave biopsy that's completed first to establish that it is a diagnosis of SCC and not something else. A surgical incision is needed. Mohs surgery may also be needed depending on the margins of the lesion. May use curettage and electrodissection for small lesions. Any poor surgical candidates or candidates that might be on immunosuppressants may require radiation, photodynamic therapy, fluorouracil, or imiquimod. Follow-up after the SCC is removed is every 6 to 12 months for 3 years and then annually for life. Patient education is similar for both AKs and SCCs. First, you want to wear sunscreen with at least 30 SPF that's water resistant and a broad spectrum. Reapply it as often as labeled. Wear protective clothing and a hat when out in the sun. Utilize shade whenever possible. And just be aware that water, sand, and snow intensify and reflect sun rays, making it easier to burn. And do not use tanning beds. This is a flow sheet that leads through kind of steps from the damaged skin all the way through an invasive SCC. So first you have a photo or sun damaged skin. After that you may develop actinic keratosis or AKs. Then you may develop an SCC in pseudo or Bowen's disease, which is where the cells are not past the epidermis to label it as a full invasive SCC. And lastly, you have an invasive SCC where the SCC cells are through the epidermis into the dermis past the junction. Thank you for the time for reviewing and listening to my presentation. I hope this information helps you with your studying for the upcoming tests.